I think what I might actually do. No, I'm gonna take this with me. Look at you bringing some drugs with you. Good job.
So we can prevent overdose.
Tremendously.
Good evening. Welcome to this second group lectures on faith and work. My name is Meredith Roop, for those who don't know me. I'd like to thank Dean Haig and Trinity Williams and my daughter Magenica, says she can't hear me. Right. But I'd like to thank Dean Haig and Trinity Williams and my daughter Magenica for doing the footwork for tonight. Tonight's topic is the opioid epidemic, pushing back. In the 1930s, there was a social epidemic has become. Well, so I called the pastor of that town to see if he could help them out. He found out more information. Pastor told me that in that small West Virginia town, there was a death every other day.
over prescription by doctors. So why do people start taking opioids? Okay. Wendy and Jim, can you hear him in the back? No. Okay. Okay. So he said reasonable use, and so reasonable use, somebody shout out, why do we take opioids? Pain, right? I know Danette is going to talk a little bit about pain and about trauma and the relationship between trauma and disease. So that's what we're here to talk about. So I'm going to stop talking myself and ask you, Dr. Dewis Miller, to say a few words, and we're going to go right down the line. Does that sound all right?
So I have a couple hours to talk, right?
Yep.
Okay. I'm really passionate. I'm really passionate about the opioid epidemic for multiple reasons. I was a social worker before I focused on I worked as substance abuse. But personally, I have a husband. During this time, and I, as the good wife, gave him his medication. He barely function. But the drug interaction from a prescription, just like the gentleman had said, was I gave him exactly his prescription. It was not overuse of the medication, but it was prescription medication. And as he never talked to him about the side effects and how they would have drug interactions. And that was just kind of a beginning marker for me. With your pharmacy school, I was pretty intrigued by all the things that were happening with psychology. So I like substance abuse. But I like learning about things that cause people harm. And I've gotten really involved in the opioid epidemic in Grand Rapids, involved in a harm reduction program called the RED Project, where we really focus on harm reduction. I'm not an advocate for drug abuse or drug use. I am an advocate for saying that that's not the life sentence that a person should because of the choices they make. So if I have a patient or if I know somebody who is using a substance and I can help them get safer use, crack pipe, and they have sores on their mouths, and they're using and they're sharing it, and they have Hep C, they can get Hep C from another person. If somebody is using dirty needles, there's over 100 people in one weekend that I got HIV. They shared needles and shooting up for HIV. Shooting off heroin, and they all got HIV. I'm an advocate for making sure that we have harm reduction resources versus making that be a life sentence for somebody. I could go on.
Well, hi, thanks for coming tonight. My name is Chris. I am from a small community, and it's a community where everybody knows everybody. You know everybody's parents and everybody's siblings. And we had quite a heroin period of about 2 months where we lost 3 people. That's very prevalent. So it was something that was really weighing heavily on my mind. And my wife and I decided to come up with a plan. We contacted my pastor, and he decided that we could use the church as kind of like I had to put our resources together. We placed some phone calls, and we got a hold of substance abuse counselors, parents in the community who have lost their children, and just basically other people who recognize the epidemic for what it was. Realize that like this isn't going to be arrested. We're not going to Narcan our way out of treating this. Like the only way we're really going to get through this successfully is by creating awareness that it leads to prevention. The only way to do that is get community involvement. You need brothers and sisters and moms and dads and grandparents to know what to look for, to kind of know how to prevent it, develop a plan inside the house, kind of just go from there. I feel like we've been very successful. We've done lots of stuff in the community that has led to the awareness. We put on a symposium last year. We got quite a turnout. The local news groups were there. It was very similar to this. It was in the local high school. Got good results from that. We've walked in some parades. We've handed out flyers that discuss signs and symptoms of things to look for. And been very, very active in school. Got together with principals and football games, post round. Been very active in the community. Been pretty successful.
Great, thanks. That's Jagger.
As they mentioned, my name is Father Jagger Fickle. And first I want to just congratulate all the students that are here. Probably half of you have to be here because of class, but the reason why it's important is I think I'm not specialist in the field as these are when it comes to the medical and when it comes to policies. But I do think what I bring to the table is the element of the heart, the human heart. What is the thirst of humanity, the longing of humanity? And unless we address it at the most fundamental level, which is beneath just psychology, and I wish there was a psychologist here because I would bring that one. But unless we get to a part of the heart that speaks beneath just my body, I'm going to be speaking from a Christian tradition where I believe not just a body, but we're a body. And so what is the end for that soul? What is its hopes, its aspirations? And I think until that's addressed and we begin to look at those parts of it won't bring an end to the epidemic. Not to undermine all the things that are being done, because a lot can be done in order. So that's just, I guess, why is there a priest at this thing? There's my quick and short answer. My personal experience of it, I've only been a priest for 2 years, so I'm going into my 3rd year. Within those 2 years, I've had 2 people commit suicide through overdose. And like your own husband, it was not, he wasn't in some dark place. It wasn't the life thing. He was in his 30s. He had a young family. And it was just taking this prescription. And I arrived on the scene pretty much shortly after his wife had woken up and found her husband dead beside her. And she was hysterical. And I walked with her then for the next about month, allowing her to grieve and go through this process. To address the issue that she had to deal with just through procedures and we got to put this in place, which just had not affected her. What she needed to understand was the appeal to her heart, and also understand the appeal to her husband's heart. And so I guess that's what I hope to bring when we discuss some questions that you have. Let's go beneath the surface and ask those more fundamental questions.
I'm Detective Lieutenant Joe Lambroth with State Police. I run the multi-jurisdictional task force that investigates drug crimes in this area, specifically Nuevo, Macasta, Home, and Ione County. I've done so for 18 years in those 4 counties. So my experience bringing to the table today is that I've seen the change in atmosphere of what drugs are prevalent in our communities, what drugs are abused in our communities, the swings from drug A to drug B. It's a diverse area, but it's changed over time. And with the introduction of prescriptions, specifically Oxycontin and oxycodone in rural counties for pain treatment, and the availability on the street, the pulling back of some of those drugs, and then the rise of heroin and methamphetamine. So I bring to the table the experience of that side as well as the enforcement side, because availability does affect everybody's use, and that's part of my side.
Thanks.
As Dr. Hayes said, my name is Danette, and I am on faculty here in the MSW program and practice. And one of the things that I am huge in both the classroom, but I'm also a private practice. And my background is in substance abuse, intervention, prevention, and treatment. I went to CMU with my bachelor's, and that was what my first job was. I worked in a treatment agency for several years. And one of the things that I learned is, to me, because I've been around since that time, so early 90s, that this opioid epidemic has been an epidemic since then. It, like you had said, it kind of goes in waves. This is not something that's new to those of us who have been in the treatment realm. We have dealt with people that are addicted to these substances right along. One of the things, though, in my master's program and in my private practice that I see is, one, I see my college students with parents at home who's an addict, and they leave home and they have to worry about their siblings and whether or not their parents are okay. I also see the relationship of the ACE study. So students, I would encourage you to look up the ACE study. It's the Adverse Childhood Experiences Study. It was conducted in the late 90s. And what this study shows is the number of people, 400,000 people were studied and are continuing to be tracked, that experienced childhood trauma, that their level of chronic pain, reaching out to their doctors for diseases such as rheumatoid arthritis, fibromyalgia, Crohn's disease, IBS, and so on and so forth, is directly related to their ACE score. My approach in my private practice, and I hope I teach it in the classroom as well, is prevention. Instead of reaching for a script, what else can we do to help people manage their pain? And so I myself do a form of therapy called EMDR, eye movement desensitization and reprocessing, which helps with somatic issues, which is physical pain. You don't want to say that it's not, but that pain that might be caused by life experiences as opposed to maybe, if that makes sense. The origin is different. So hopefully I can bring that perspective of our holistic approach.
Thank you all so much. So you'll see me up here. I'm not out here tweeting or texting my friends. We're actually live streaming this, and we are tweeting. I'm not tweeting. Paul is tweeting. Some of the comments that get made today. So this is how we're communicating with each other, and it's also a way for us to get sound to the live streaming. So I think it's important, I'm not up here just goofing around. Who has the cube? No cube. Boring microphone. Okay. Does somebody have a question to start us out with? See, I'm an old biology teacher, so I'll stand up here till the cows come home and just wait. Thank you, Dean Larson.
Very genetic component to addiction behavior.
Yes, there can be a behavior. There's study shows that some of our pharmacogenetics, if we do a study on a person, we can look at different can't think, I'm on the spot now, I can't think, different, the pharmacogenetics. The DRD2 is the one. Receptor.
Yeah,
Thank you. The receptors and different chromosomes that we need to look at is that we can say, yes, this person has a higher tendency to have an addiction. It doesn't mean that they have to have an addiction, but they could have a higher tendency. As I was about 2 weeks ago, and the presenter said somebody that is born to parents that have genetic predisposition are going to have a higher likelihood of having addiction. But let's say you're born to two parents who do not have any addiction. And so that means you don't have any genetic predisposition. You can still have an addiction. And if you develop an addiction, there's physical dependence, there's tolerance, and there's addictions, and they're different things. But if with two parents that don't have any addiction genetic traits, develop an addiction, then my children will have a genetic predisposition. So genetics can be modified pretty quickly.
Jeanette?
I think that goes right into all, it's not, we want to talk about opioid addiction, but that's part of the patterns of families, right? And we know that epigenetics also is very interesting. You can have children raised in a home with child abuse and neglect. They grow up to have children that are not. They are resilient and they do everything right, but guess what? There's those aftermath of what they've been through is still present and still can be carried on to their children. And so I think that is also critically important when we look at prevention, that we have to look, we can't just look at the current generations, we got to plan for the future. What are we going to do to address this?
Thank you. So we just had our first question come in from the live stream, and it is, have panelists discuss why opioids in particular? There are lots of classifications of drugs, so what makes opioids so special? Joel, do you want to? Detective Lieutenant? Because, right, you're talking 23 years of experience in drug. Yeah.
Why do people take drugs is the question, right? They make you feel good. Opioids make you feel good. High school student sprains their knee in a basketball game, goes to the ER, doctor prescribes them heroin. So why are they giving their child heroin? But instead they're prescribing an opiate. And instead of giving a 2 or 3 day supply, they give a 30-day supply. So that person gets done with the need for the opiate, and they're still there in the cabinet. And when they took it, they made them feel good. And continue to take them because they make you feel good. Well, eventually you become addicted to them. And now you take them because you have to take them, or you have that addiction. So, opioids are just one of many drugs. Other drugs, methamphetamine, is not an opiate, but it's addictive. And it all comes down to why do they start, and sometimes it's because of a prescription, but at the end of the day, they start that early on is because they make you feel better or feel different. That's why they start. I don't know if that answers the question, but that's kind of where we're at with. Now, opioids have their own unique characteristics. Methamphetamine has its own unique characteristics. Marijuana will have its own unique characteristics. There's different drugs out there, but at the end of the day, the start is it makes you feel better or different.
I was reading a quote from an addict that was taking opioids, and he described it when taking an opioid as a warm hug from Jesus. And I think that speaks to what that type of drug gives you. So it's not psychotic. It's not I'm gonna go get stoned and have some hallucinate, whatever the word, whatever the word I'm trying to say. It's a feeling at the level of the heart of warmth, of being comforted, which I think is important to realize. Like, what are people running away from? And I think you see this in the culture, a huge cultural shift in understanding suffering. You can correct me if I'm wrong, the older generations, but 50 years ago, there was a place and point of suffering in the culture. It made you grow. It helped you to build character and strength. Where I think what we've seen is a cultural shift of we don't want any type of suffering, even to the point of euthanasia. I will rather die than take suffering. So I think that element has something to play too. Why does the human soul, why does the human spirit find suffering as so adverse? I don't want to deal with it. And I love the feeling of a warm hug, something that comforts me. So I think that also can speak to why this drug in particular.
And it's easy access. We have something that comes legally, prescription, so it must not be bad for us. And if a doctor gave it to me, there must be no side effects that are bad. Start out and we get that warm, fuzzy feeling or numbs the things that we're dealing with. It's legal, so it can't be bad for us. It's more about lack of education, and it started out in a very legal manner.
Chris?
Not only is it readily available, how many of you have them at home in the cabinet? The symposium that we put on last year in the fall, we had a DEA agent come to, and he had said that 4 out of 10 people that come into your house and have to use your bathroom for whatever reason will go through your medicine cabinet at some point. A lot of people. And how many of you keep your opioids in your medicine cabinet? Grandparents do the same thing, or it's sitting out in the kitchen above the sink, easily available. Kind of the bottom line.
Okay.
Hi, thanks everyone. So this is a question I'd like to start with Lieutenant Joel with it, and it's about access. I know your expertise is in meth. I've heard that lately meth is shifting back from being locally manufactured to being imported from Mexico. When access and the availability of opioids or other mind-altering substances shifts so frequently, how do you reduce access from an enforcement perspective? And the second part is, how do you enforce that without creating so much stigma that it keeps things underground so that it's more difficult to address the needs of people who have fallen victim?
Give it a try. Well, a little background on our area, the Fort Rural County area. And as we've seen, prescription opiates specifically introduced itself in the late 2000s. Then our traditional methods of getting drugs in the country are imported from other countries. The mechanisms to bring drugs from other countries to here are standard drug fighting, agree or disagree with the war on drugs, but we know cartels import through certain channels into our country. Methamphetamine hit the scene for a while and people could make it here, and it was easier, and we saw its availability, but the cartel said, hey, there's demand for that, so now they started importing methamphetamine through those same channels. There's word on the street, I guess, that we're seeing that the crystal methamphetamine importation structure is going to start moving to the synthetics, the fentanyls and the heroin, because again, there's a demand for them. So part of the fight of that in the community, and I'll use the UP for an example, is there's an article in a news or television newscast this morning speaking of Bergen County and one other county up in the UP, where in the last 3 to 6 months they've seen a huge decrease in Narcan uses, arrests, and the availability of heroin. Well, their investigations up there led to one of the upper level people in the community that was bringing it into their community. Once they were able to eliminate that source to the community, the availability. Now, people that are addicted are going to go elsewhere to find it, but it is one of the traditional ways we're going to have to fight this. I mean, there's different answers here on the table, and again, you can't arrest everybody, but you still have to have some enforcement because there's going to be availability and we're going to have to fight those. Does that make sense on to your answer? We explore all different kinds, but we focus in our work area. We don't have source areas. We aren't a source area. There's nowhere in 4 rural counties that I find a person buying kilos of heroin or kilos of methamphetamine. However, I do see small groups of addicts grouped together where one individual will travel to Grand Rapids or to Lansing and buy an ounce or a half ounce and bring it up and distribute to those. So in our area of enforcement, we focus on those mid-level dealers that are bringing it. It's not going to eliminate the drugs on the street, but it's going to help improve those local communities. So those are some of the types of enforcement actions we take. The state police don't just focus on enforcement actions. I'm speaking of, that's my job. My job is to investigate drug dealers and arrest them. The state police, they have the Angel program, which is across the state, where an addict can report to a post and seek help for addiction recovery services that way. So there's the prevention side of it as well. It's just I'm on the enforcement side of it. That was a big question to ask.
Yeah.
Okay, I actually have another question. This has to do with recognizing the signs of addiction. So whether it's in myself or, if I'm taking a prescription and all of a sudden, do I have a problem with this? Right? What are the signs? How would I know? Or in somebody around me, like when you were giving prescriptions to your husband, how can I recognize the signs? What can I do about it? When do I need to start intervening? What are some of the things like?
So it's part of my private practice. If you need a client, I've learned in this field, like for suicide, you don't beat around the bush. You got to come out and ask. So I always ask, do you use substances? Are they prescribed? Are they street drugs? So we talk about it. I don't judge. I can't help them though if we don't establish a trustworthy relationship. And so interestingly enough, recently I was referred a woman that was what most here would certainly consider elderly and was on a lot of medications, 9 prescribed meds, including opioids and benzos. And so part of our discussion was filtering through, do you need them? Do you really need them? And so one of her goals is to get off of these things. One thing I will tell you though, because of the cocktail med she's on, that is something that I must be in collaboration with her healthcare provider. It is not advised for someone to go cold turkey. That is can be very dangerous for somebody. And so together we're working through that. But when there's any client that comes in, and by the way, even children, I ask them. I have learned many years ago, I worked in the schools for 17 years. I am well aware that there are elementary kids that are experimenting and using substances, including prescription opioids. But I always ask. And we work on building that report so that we get honest answers and we can get treatment going.
Please.
So I also want to just affect that there's a difference between addiction and symptoms of overdose, because my husband was like on day 2.5 when he almost overdosed. And so there's symptoms of people not being able to breathe, people having different side effects from an opioid versus the addiction. So if you're sick, and I try to help my students, so I teach pharmacy students, to help them to understand the difference between tolerance, physical dependence, and addiction. And basically, this is what I say to them. How many of you drink coffee? Anybody drink coffee? All right, so a lot of you drink coffee. So how many of you really get going in the morning with just like one sip? Yeah, right. So there's a lot. So you may have started out drinking one sip or a little bit, but then you built up a tolerance. Now you might need a cup or two. Some people might need 4 cups of coffee to get really to being able to have a conversation. So let's say I say to you, you cannot have your coffee for 3 days. Tomorrow, are you going to wake up and be energetic and going? Or are you going to be thinking about, I need my coffee? You're going to need your coffee, right? So that's a physical dependence because you need it to wake up and to get moving. But how many of you are going to go and knock up or Starbucks? How many of you are going to steal somebody's money to go and buy that? How many of you are going to lie to your friends about where you're going? That change in behavior, the lying, the cheating, putting that need for whatever their addiction is for their own well-being, for their family's well-being. They give up the things that are good in their world because they don't see it that way. They only see this need for that. They need this medication. They need this drug, alcohol, or so there's a difference, the understanding that there is a major difference between opioid overdose and addiction.
Other things that you can see too are kind of distancing yourself from family and your friends, just regular isolation, erratic sleeping schedule, the lying and the irritability are big ones. Financial problems, weight loss, avoiding meals, pinpoint pupils. Those are kinds of things, the signs that you would see of someone who's up to habit. It's really just become a lifestyle at that point of lying. How can you get more money or what deal so you can afford your fix? To distancing yourself because you can't use when you're around your family, and if you're afraid to use when you're around your friends, that's why the isolation tends to occur. Sleeping habits means people are alone at night, which is drug use.
It's pretty bad. And that list also just a lack of interest in the hobbies you once liked. So the thing that is most important now is the feeling. And nothing else can compete against it. And I don't know if someone can speak to the neurological reality that's taking place there. That at the neurological level, you really can't compete against it. And so maybe you could delight in going fishing no longer is that delightful because it doesn't give you.
I have a question. It sounds like opioid addiction
No.
I'll talk about it. It sounds like it's pretty prevalent, and just kind of moving forward in the same line of conversation that you're in, and maybe it's Chris that would answer this, but can you give an idea for how prevalent opioid addiction is in Mecosta? What would be the typical journey that you would see somebody with an opioid addiction traveling in? Certainly not all of them are overdosing. What would be maybe some examples of typical journeys that somebody becomes addicted goes through?
I can't speak for Mecosta County. I can't talk to you about the level of overdose and fatal overdose over the last 2 years. We're talking 130 people are overdosing, with 75 of those being fatal. It's become such a problem that the ambulances that now actually carry 10 milligrams of Narcan in them from the 4 that they were previously carrying. As far as the traverse, the plan, I guess you could say, the journey that it takes them on, like they mentioned earlier, a lot of this just started off as, you had surgery or you got hurt, and it led to you being prescribed medications, and really just snowballs from, the warm hug feeling to now I'm out of medication. And you start searching for it. Is it in grandma or grandpa's house? Is it in so-and-so's house? It's not there. Can you purchase it from someone? You might have an overdose where you end up going to the hospital, but want to treat you for inpatient and you refuse, and you go have this cycle that continues over and over again. But then, you run out of the actual opioid and filler, the heroin, which in our area, we're having a big problem with heroin being cut with fentanyl and carfentanil, which that's where people are dying. They don't know that it's cut with fentanyl, and they're using the same dose that they were using when it was cut with a substance that wasn't harmful, and they're dead. I mean, that's really the pathway that it goes down. Not really a whole lot of deviation from it. I mean, you kind of run yourself into the ground financially, physically, emotionally. You're gone. Like, your connections are burned. You don't have any trust with anyone around. You just isolate yourself to such an extent that that's all you have every single day when you get up is where are you going to get your fix from? How are you going to get it? Work doesn't matter. Family doesn't matter. Snowballs and plummets. Yeah.
Can we talk a little bit about fentanyl?
I was actually going to ask Joel to answer the rest of that question about,
I can address the availability.
Yep.
In Nuevo, Mecosta, Mount Coleman, that's our area. I would say our heroin hotspots are Mount Coleman County. It's directly related to probably 3 or 4 doctors in the area who heavily prescribed Oxycontin. We were buying Oxycontin quite regularly in those 4. Mount Coleman County had 17 overdoses, and I think it was like in 2001 of Oxycontin. Well, as the medical profession saw the dangers of Oxycontin, they started pulling that off the street. Harder to buy. I could purchase a 40 milligram Oxycontin for $20 in 2000. It's well over $1 a milligram today. So we don't buy Oxycontin. We don't buy those opiates on the street anymore. We see morphine and some other ones, but as a result of that, you had a lot of opiate addicted people, and where there's demand, there's supply. So we started seeing Greenville, Belding, Ionia. That area was our heroin hotspots with a little bit of heroin available in Nuevo and Mecosta County. In the last couple of years, we've seen increase in all of the counties of the availability of heroin. You don't see a large heroin use in this population, the college population. We don't see a lot in the high schools yet. But again, like any drug, the more available it is in the community, the cheaper. But in Mecosta, Nuevo, Mount Coleman, Ionia, Greenville, Belding, Ionia, that's a heroin hotspot. Overdoses are up, Narcan use is up, our purchases.
And just follow that. So that's part of the journey. So I think everybody can probably hear me.
no, they can't. Use your microphone, please. Yep.
Can you hear me?
Good.
Okay, you can hear me. So that describes a lot of the journey of addicted and going to a path of destruction. maybe talk about a path towards recovery, what you've seen, how somebody has been, maybe there's an intervention or whatever, and what that path to recovery is, and maybe some of the practical issues too, as far as insurance and how that rehabilitation would take place.
One of the paths I can speak to the state police's Angel program. If an individual has an opiate addiction or any addiction and they seek help, how did they get help in the past? And the purpose of that program is for an individual to go to a state police post from 8 to 4, go to the front desk and say, I'm an addict and I need help. And they have referral programs, they have volunteers that come in, community members that come in, and basically become guide for that person that's seeking help. As far as treatment's expensive, and how that gets done, that's above me, but there's guides there to help people find the treatment out there. Other programs out there for the addict or that I've been involved in, Mount Plum County and Ione County have a very active drug court. Drug courts are some solutions on it as well. When you have a subject that's involved in a lot of property crimes, larcenies, and things of that nature, and they're stealing because they're a drug addict. And drug courts put them in connection to intensive supervision and other things that put them through steps. It's actually more supervision, correctional supervision under a drug court than just going to jail and get on probation. But with anything where there's more costs associated with that as well. So there's a lot of different options for that addict to seek help. Some court mandated, some voluntary, but there are those avenues available. But ultimately, that person has to make that decision to do that themselves with family or friends. But other than the drug courts, there is no, I arrest you with the possession of heroin, I'm going to send you to treatment.
Jeanette?
One of the things that I think is important that has changed for in my opinion, modality, is that under the Affordable Care Act, and we'll get into the politics, but I'm just going to tell you that it used to be many individuals that had state insurance could only go to specific agencies. My private practice is in, we are private clinicians, and we, Melina and Meridian, Medicare, the only form of insurance we don't take is straight Medicaid. And if we get a client, whether it's an addiction issue or not, and by the way, the vast majority of individuals who are addicts have dual diagnoses. It's not just addiction. Chances are there's some anxiety, depression, many other things, PTSD that goes along with this. And so one of the things I'll share with you is that we also will help them in getting, there are avenues to getting their form of state insurance changed so that it is accepted at more agencies. The other thing in the world of addiction is we do recognize as a nation that it's a problem. And so since I started in 1994 in a treatment agency for addiction and treatment services, what has happened though on the other side of it, prevention funding. And I am to the core a prevention-focused individual. And we have to address those people who are currently using by all means. But we also have to address our younger generations coming up and to try to stop them from starting. And that, to me, is absolutely imperative. One of the things that was also a goal was parity. And I teach my students this term. It's important to understand. It's equal funding for mental health services as physical health services. And we are nowhere near that. And that would, if somebody said, what's the one thing you'd see that would really help with all addiction, not just opioids, in mental health, is equal funding.
If I could just speak briefly. So addiction comes from the Latin addicere, which literally means to lose one's voice. So it's getting at this aspect of my freedom is taken away from me. So you talk about there are avenues where someone can seek out help, but an addict doesn't have the freedom to seek it out. There's a binding of his will, her will. Well, speaking from just the Catholic perspective, we're all addicts, right? There's an element to each one of us that are addicted to something, to sin, to something in my life. And I think why it's helpful to bring it home is because it's very easy to say those addicts, these people that have a certain problem, and how are we going to help them? But when you put yourself in the fold, now those addicts become, you're a part of them. It's your own family. A great philosopher, theologian of the last century, his name's G.K. Chesterton. And he has a beautiful phrase. He says, we're all in the same boat together, and we're all seasick. It's true. There's this reality that each one of us suffers from an addiction towards something that's not going to bring me complete happiness, right? And you can all think about that if you think about it personally. Now, what gets you out of it? Can you pull yourself up from your bootstraps? There's ultimately a level of saying, I need someone or something to come into my reality and help me get out of it. And that's the first step of AA and NA. Admitting that I've hit rock bottom. Admitting that I need something or someone, a higher power beyond myself to help me. That's important for all of us. So I think a part of the recovery is recognizing, for one, I need help, and I need someone to help me.
First of all, thanks to the panel. These are great points you're making. One, I'm not sure who should answer this question, but we're facing an election in a few weeks where we're potentially going to legalize the recreational use of marijuana. I've heard marijuana described by an addictionologist as a gateway drug. And with that said, and I'm not trying to be an alarmist at all, but what do you see, what do you fear, maybe you're not concerned about the expansion of the use of marijuana potentially pushing the opioid epidemic or whatever that next epidemic is forward?
Who wants to take that one?
All right, I'll go there first. I'm going to tell you the medicinal use of marijuana has been widely researched. So the difficulty I have with it is it's not that I'm not open to the medicinal capacity that exists. The difficulty is what we see now is the THC levels in marijuana are so inconsistent. They aren't what they were in the 70s, I assure you. And so one of my concerns is the risk level with marijuana. The potency is so much higher than it used to be. And so it's not that I personally and clinically don't see some value that it could bring to people. I believe that it needs to be carefully thought out. I see pros and cons.
I'll jump in. For me, this is recreational approval versus medicinal. If we were doing it medicinally, we wouldn't be smoking it. Because I don't know anybody who has gotten well from smoking marijuana. Because smoking is still smoking and emphysema from that. There are studies out there on THC versus cannabinoids. Cannabinoids may have some relief for some of the pain, and I work on a lot in pain, but it's not to the point where we know exactly what levels need or what is the dose of it. I still have patients who come in and they still ask for more opioids, they ask for more medications, and the marijuana is not cutting it. There's some people who will swear by it. I am not an advocate for smoking marijuana. I'm not an advocate for any legalization of drugs that can lead to harming people. I think it's a huge topic that I really want to say not it. But I don't think that we're at a point right now where we can say recreational marijuana is going to be medicinal purposes all the time. This is my medicinal card. Tell me what is wrong with you, and let's really talk about maybe it's the mindfulness, maybe it's the other things. 22-year-olds out there who are using it for pain. Well, pain is a normal reaction, and we need to be able to respond to pain. It tells us not to do the things that we're doing. So just be honest about it. It's more recreational, and I think it could be a gateway. If people are using it recreational, if you're using it medicinally, then you should never be.
I'll agree with the not having to smoke it. There are numerous other ways of using marijuana, cannabinoid aspect of marijuana without smoking it. But I feel like research has shown tremendous improvement as far as like even epilepsy goes. Pain management in cancer patients. You don't have to worry about respiratory depression in cancer patients. So are you supposed to not treat somebody like their bone cancer, their pancreatic cancer with all this pain they're going into because you can't keep feeding them opioids because they're going to have respiratory depression at some point. So it's kind of a nice method to treat pain. I'm not an advocate of smoking it either because huge respiratory implications as far as that goes. But I feel like it's shown some promise.
I think THC is the issue, and maybe not the cannabinoids and the other things in it. Marijuana is not the same marijuana as everybody has seen in the past. We see marijuana THC levels up to 28 to 30%. Marijuana in the 60s was 1 to 2%. So the THC levels is the key thing. I don't think marijuana has been studied in any. The studies I have read is study marijuana at 11% THC. What are the effects on the developing mind of children at 11%? And it's not been good. So the marijuana that we're talking about legalizing has not been studied to the extent of the marijuana in the past. Strictly speaking, from the state police, we don't have any comment on legalization.
Thanks for that disclaimer. So we actually have 4 questions lined up right now. So we'll go Dr. Samuels.
Not right. There you go. Okay. It seems like when we ask the question, how to deal with the population, there's a couple levels on individuals, but there's a larger picture here to physicians that are being pressured by the drug companies to prescribe certain drugs, and there's another policy issue with regard to the fact that the insurance companies are kind of dictating to our legislators not to put any limits on what they do. So I'm wondering if anybody in the panel can speak to the larger issue, and I'd also like to challenge the young people in the aware of the more political policy issues that still face us with regard to this issue.
From a statewide strategic plan, drug enforcement, one of the focuses is not just opioids, but prescription prescribers over prescribers. There are doctors, and I investigating doctors today, that are over prescribing prescription medications, both for profit and it's just what they do. So at a state level, from a law enforcement perspective, we've been tasked with looking into those doctors that are doing it for profit, that are over prescribing, because they are out there, and then take legal action and go that route. So there is some steps in that over-prescribing aspect of it. I knew there was some recent legislation requiring limits on, which you're speaking of, limits on the running of the use of MAPS. If someone's not familiar with MAPS, MAPS is a program that tracks prescriptions. Doctors need to run MAPS if they're prescribing more than a 30-day supply of an opiate, so things of that nature. So there are legislative things going on, but there are a focus on over-providers, people that are putting drugs on the street in bulk more than the normal medical professions, from at least a law enforcement perspective. We are focusing.
And there's a lot of information coming out from the CDC and at my level. So in my clinic, we opioids as well as the number of pills that go out. And from the CDC from 2015, at the level where I am, we are seeing a decrease in that. We have a lot of education going out to providers about overprescribing, about just having those conversations. I work with a lot of providers. I work with giving presentations talk about the plan of if you have to give a prescription, having conversation. This is a medication and what it's about, and even a lot of counseling and sign off on. But a lot of the providers are now having meetings with their patients and talking about the risks and the benefits and tapering off. They're going to see a lot more of that occurring, not just because the insurance companies aren't paying for it, but a lot of the providers are, because they're being investigated by the state.
Mike.
First, I want to say I really appreciate the diversity on this panel. Everybody's perspective here is really valuable, and I like that you're really trying to make it in that, you're addressing of the stigmas and compassion that we need to treat. And I guess that really gets to my question. I see you got naloxone and stuff. I know you work with Red Project. I want to hear some discussion on harm reduction versus criminalization. Mainly, if somebody could, maybe in reference to Portugal or Vancouver, and the effectiveness of harm reduction techniques over criminalization, stigmatization, as somebody who has struggled with problematic use on and off throughout my life. The use of the word addict makes me not want to seek your services. Say problematic use, I am a little bit more open. So I want to hear this harm reduction bit because for me that's what happened.
So I work with the Grand Rapids Red Project, and it's based upon the recovery program and the San Francisco Hope. The Hope, I can't remember the exact name of it, but it's a harm reduction program where it's really about, for people who are actively using, having resources available to them so that they are not harming themselves more. So at Grand Rapids Red Project, we have recovery coaches, people who are in recovery themselves. If you're at a point where you want to go into recovery, then there's someone there. We have people who give out safe supplies. We give out needles. We do needle exchange. We give out condoms. We give out pipes. And not actually the pipes, they're the mouthpieces that go along with it. But really making sure that people understand how to be safe. If you are using, it's not, if I cross the street and jaywalk, should I go to prison? No. So we need to get out this mindset of the criminalization of it. I understand that we have laws, we have to follow them. But because I have an addiction, does that mean I shouldn't have harm reduction? Should I not have the availability of resources? I believe that everybody should have those resources. Also with heroin, besides the needles, I'm not really savvy with all the words and the terms that we have, but we give out what used to be the steel wool and stuff to clean your needles. Give out the mixing. We also have naloxone, so we have naloxone kits. And Red Project has not only gotten involved with harm reduction, but saying, let's advocate for Good Samaritan law. If I'm using, and Chris is using, but Christy, you're not using today, but we overdose, but you've got some paraphernalia at your place, and are you going to get in trouble? She may not call the police to help us or 911. There's Good Samaritan laws out there saying now you can call for help and you're not going to be arrested. If you have a warrant out for your arrest, you're going to get arrested. But the Good Samaritan laws say that if you're calling to help somebody, you're not going to be arrested for your use that day. So really advocating for the harm reduction, not criminalizing, there's offering guidance. So also if somebody does overdose in Kent County, a recovery coach is given the contact for the person who overdosed. So let's say I do overdose, I go project's information, sign off saying that yes, somebody can contact me. Red Project goes out to your home, goes out to your family. Would anybody like some services? Nope, get away from me, and that's fine. We're here. Do you have naloxone? Do you have naloxone? Because we want to make sure everybody has naloxone. So it's making sure that people understand that just because you're using or you have an addiction doesn't mean that you don't deserve service. You don't deserve to be treated as. So really making sure that people understand that there's harm reduction. Now, I think Vancouver and Portugal have safe houses. That's a bigger topic where it's people can go and use drugs in this environment. And problem is there's a lot of grants that these harm reduction agencies are part of, and the grants people are still like, no, we can't just have somebody using drugs. So it's a little bit more difficult.
Anybody else want to? One more panelist to speak on that.
Chris, actually, I think you would probably be better than me, but I think there is an element of how does the community, the local community, have agencies that are doing things? How can the local community create a view of this person that's not right off the bat, oh, this person is a criminal, or this person is, he got something wrong with them. And I think that's probably what you're pressing at more is how do we as a society begin to view others in their brokenness, in what they're suffering from, not as that's who they are, but here's someone who's suffering, and how am I called to accompany them in a process of healing? And that, I guess, just goes back to what I was talking about before, is once I recognize in my own self that I'm pretty broken too, then it opens my eyes to others. And so I think that's the Christian element.
Thank you for that.
I kind of have one now adding to that one, but I have another one also. So, dang, I just lost it. Okay. All right. Well, I guess I'll just add my original question. How do you combat the stigma that addiction is not? Because all over Facebook, you see people phones and like they just need to quit and everything, but that's obviously very unreasonable. And so I just wondered how we can best help educate people on the facts, on the notion that it's not a choice.
I would say you respond back and start with yourself and feel empowered to educate others. I feel that way with all mental health concerns, not just substance use, right? Depression, anxiety, until we learn to be open about these issues. And so I agree, and I see those posts on my own social media, and I breathe a little bit and practice mindfulness so that I respond appropriately, because some of the things that I want to write would come out not very appropriate. So I get that, but I think if all of us in here, one by one, can start taking a stand, it's amazing what will happen. That ripple effect, that if we begin opening ourselves and educating others, that's where it starts. And I look at the young people in here, and I look at you with hope. Like, help us. We know that we need young people to lead us in this, because ultimately, we're not going to conquer anything without you. We need you on board. So simply starting with a post back and saying, well, actually, here's what, here's my research, here's my opinion. That it's great, because you're opening up for that stream of back and forth that might happen. But if respectful dialogue takes place, that's what first starts.
I think education is important to never start down the road, because an addict or someone that needs help doesn't have a choice. They had a choice at one point, at the very beginning, to use the drug the first time. Prior to that, they're not an addict. They don't have to have heroin. They don't. So some get their different methods, and maybe it was from a doctor's prescription that got them there. But educating early on, so we don't get to that point, so that one choice they had that very first time is gone. Heroin's not safe, or these drugs aren't safe, but someone has to try it the first time.
Is it part of the problem that it wasn't a choice? That it's being
That is
prescribed
some
to
of the
you?
problem. Some of the problem, yes.
Okay.
But not all of the problem.
And so then, do you guys see a trend in people are
It's a huge increase after persons have changed. whether it's in recovery, if it's incarceration, not using, and then all of a sudden using again, it's a huge. And there's a lot of programs occurring now within the jails and the prisons about having tolerance change and getting.
What most people don't realize is recovery is a lifelong. It's not 3 months or 6 months or a year. And it's over with. You don't ever have to worry about it. Every hour of every day, whoever's in recovery is battling. And, like we talked about earlier, it becomes an obsession. It is your mind fighting to justify why it's acceptable to use this. And, people are human. They give in. They make mistakes. And I think that's kind of where the stigma needs to change, because people that have never been exposed to that, they don't realize, the fight, the depth, the consuming capabilities that it really has over. And I just think that's kind of where we need to see the opposite side of the coin.
So very back of the room.
Hi, okay, I just have a question about Narcan use. Just kind of what are your guys' thoughts on it? Do you think that it has led to an increase of, or this idea of earlier you were talking about Bay County? I actually went to Delta College and went to a seminar over there about the same topic.
I'll talk about Narcan. I carry it. So these are both ones that I carry in my work bag. I work in Grand Rapids. I'm a parent. I have a college student that actually comes to Ferris. I carry it to work meetings. That it's kind of like the fire extinguisher that people. Do you start fires because you have a fire extinguisher? There might be a person in here that might, not in here, but here or there that may do that. There's some pyromaniacs out there, and they may build fires because they know they can put them out. But I'm going to say I've never heard of somebody waking up saying, today I'm going to get so many or so high that I'm going to have to use Narcan. Christy, will you be my Narcan person? That
Sure.
doesn't happen. Thank you. But that doesn't really happen. People don't want to overdose. They're high, and the numbness that comes along with that versus the desire to want to die today. I know that some people believe that increased use of having Narcan available will, but I also have patients who have diabetes, and they will eat 3 pieces of cake because they know they can get insulin. And quite honestly, we don't put them in jail. We might have to call them in.
So I have kind of a quick question from online. If I have an injury or surgery in the future, what are some alternative pain management options I can ask my doctor to avoid issues with opioids?
First of all, I'm not completely. Opioids do have a place in cancer. If you have a in a car morphine, narco. It was a necessity, but we knew the treatment plan for it, knew how many days he was going to be on it, what was going to happen. We had those conversations. And then we knew what to do after the medications were gone. So how was I going to dispose of them if we had any left? When he also had his wisdom teeth pulled, we were going to be given a script with multiple doses of narco. And I refused that. So it really depends upon the surgery. If you're having wisdom teeth pulled and you probably are not going to remember the pain in the ear because many of us go through it, it's not that bad. You can have ibuprofen or acetaminophen. If you're having a total knee replacement, you're probably going to need an opioid unless you have a history of having opioid use disorder. And then you have to have a conversation. No matter what, you have to have a conversation with your healthcare provider to say, this is my history. This is my genetic makeup. This is whatever the conversation needs to be, because opioids do have a place, and they may be needed if you're having surgery. It's not that we can't have them, we just have to use them properly and have that education. You have to know if you're taking a benzodiazepine and an antidepressant that you can have respiratory depression, as my husband was having, and you can die from those things. So having conversations, having people know information means that we can then prescribe them safely and for short duration.
Post-op pain management it's a big deal. I mean, if someone has a total knee replacement and they're in a ton of pain and they're refusing to take their pain medications, they're not going to want to get up and start physical therapy and walking. It's going to lead to a poor outcome from the care they receive. So I absolutely agree that, opioids for, an acute setting like immediately post-op are important because the patient has to have their pain managed so they can start the treatment. But what they don't need is a 90-day supply from an ER physician after they've rolled their ankle. That's just outrageous.
I think a part of the problem, there's two sides, right? There's the availability, who's being prescribed, and then you have who's receiving. So everyone who's been prescribed opioids isn't that going to become an addict or fall into that. So I think there has been studies, but I think a lot more studies can be looked at as what in this person's life, what's kind of the setting of these people that end up both biologically or just socially that tend them towards becoming addicted to the substance. And I think that's where it becomes very interesting and where you can begin to address that. The main problem is, yes, there is a problem, obviously, of just throwing it out there. But where it becomes a problem is when someone takes it and then becomes dependent upon it. So what are the factors that makes them dependent? And I think when you see people's lives, I think when you look at the culture just from a bird's eye view, there's a lot of elements that I don't think you could just throw to the side when it comes to the breakdown of the family, when it comes to the higher rise of depression. As speaking to you, it's not just people who are being prescribed that get their hands on opioids either. Someone has it and then they give it to you. Well, what causes that person to want to take it in the first place? These are factors that I think have to be looked into as well.
Thanks. So this has just been such a great night and time is flying. I think we have time for one more question and then a very quick wrap up if any of you want to say a quick last thing. So in front. Hit the button in front because it's gone off green. There you go. Or take this one.
Thank you.
Yeah.
Hi. So I have a statement and a question. My name's Monica. I'm president of Students for Something this year. We're actually hosting a naloxone training November 1st, 6 p.m., UC 217. I never go to parties without mine, so if that's something you're interested in, you know somebody it's a great time. It's free, and Red Project is doing the training. So you've already heard some good things. Get your own kit. But my question is, I went to our regional conference just a couple days ago this weekend, and there was a girl there who had joined Students for Sensible Drug Policy because of the opioid crisis. And she has a degenerative bone disorder, and the medication that she needed was an opioid. And she was told that no doctor would prescribe her this heavy opioid because of the opioid crisis, because of the crackdown. She was told she had 2 months to live because of the opioid crisis. How do you respond to that? I never heard that perspective, and it was definitely pretty eye-opening. What do you guys think about the crackdown on doctors? Is it too much?
I think there needs to be balance. The sick person needs to really see a specialist because there are certain medications for opioids, and that might be it. I know that there's a lot of people walking around with degenerative disc disease, but honestly, most people aren't on medications. It really depends upon the provider and the education, just really having more of a balance. A lot of our providers are saying, you know what, I'm getting looked at by the state, the insurance companies aren't going to give me my bonus because of this or that. It's having conversations and really having specialists understand this. I work with a provider another pharmacist. She works in cancer and pain, the providers are scared to. This is indicated for them. So really making sure having those conversations works on, there's a difference between acute and long-term, and also the different types of medication. So if it's an acute or shorter duration of the opioid, they're being really strict on them. It's the long-acting, but prescribed appropriately, and working with them in all of the other So mindfulness. Talk a lot in my clinic about acupuncture, physical therapy. There's a lot of different alternatives that we really need to be exploring that maybe be able to decrease the amount of opioids that the patient would need. Really then looking at the whole person, what is their background, what are some other ways that we can do this. I have a daughter who lives with pain every single day, and she cries, and she's never been on an opioid, and I won't introduce her to that because I'm so afraid, but I'm at that point where it's like, what do I do? So it is looking for those alternative treatments to really say, what can we do to make this better without going to the opioid? Because I don't want the stigma. There's people who put stigma on her. Even just the words that we use and how we use them has the stigma. And I don't want my daughter to be stigmatized because of the fact that she goes into a clinic and says that she has pain at the age.
Anybody else want to comment on that?
I certainly agree. But sometimes pendulum swings from one direction to the other. And certainly we've seen that in management of substances for many, many years. But I know that the person online asked if they were going to have surgery, what, if they want to have other alternatives. That's an amazing question to ask because there are. Mindfulness is, there's many different forms of mindfulness. And it's deep meditation and prayer for people who are religious, but you can reach that level of working with the individual's mind and helping them with techniques to calm the body and their nervous system so that they have a higher pain tolerance. And that is something that can be done without the use of prescription. And so for somebody to say, hey, recognize that going into surgery, by the way, sounds silly, but there's an app for that. And there are numerous apps on the market for Android that are free. I have an Android, but I can assure you, I'm sure Apple's right there too, that you can access with guided imagery, relaxation techniques, breathing, and really some of what people who do talk about chronic pain and who are craving the next use is just get me through this few minutes, get me through this few minutes, through that few minutes, and then they need to get, and so it can be very therapeutic to have different tricks up your sleeve. And I use several apps in my private practice and teach my clients how to use mindfulness and how to do that. The thing about mindfulness that's beautiful is you can use it anytime, any place. And so if taught correctly, those techniques for coping can be.
Thank you. So let's start here. A quick wrap-up message to the folks, and we'll go right down the line.
That's a lot of pressure.
It is.
I just, my whole thing is educate, educate, educate. Talk to people, have the conversations, make sure you understand everything you can about whatever you're doing, whether it's having medications, whether it's using, whether it's about mental health, reducing the stigma through education, reducing drug use through education, everything. Just talk to people, educate them, and learn more yourself. Thanks.
I have to support that. Education and prevention, number one. I feel like it's going to start mainly in the community, at home, parents and siblings. And, you guys, it's huge that you guys came. It's a huge step in the right direction. I think this is going to be what gets us where we need to be.
An element of it is the level of the heart. I think unless we begin to address what am I thirsting for and why do I think X, Y, and Z is going to fulfill it, people will, maybe it won't be opioids, but it'll be something else. Pornography is another thing that's out there that's just as big as opioids. And what is it doing? It's affecting, tearing apart relationships. Why? I think those are the questions that are really that need to be addressed by you personally. What am I seeking? What am I longing for? which will be the prevention so you don't go to X, Y, and Z.
I think that this issue is one that has many different sides. We'll see harm reduction on one side, normalization, law enforcement arrests on one side, and the negative. You have opiates on one side that are medical purposes yet hurt people. And we just have to be open that there is no one set answer to any of this. We have to explore them all. Some are good and some are bad, but we need to explore some things and try to find that solution.
So I would like to go back to the one person that made the comment about social advocacy. One of the biggest foundations of the field of social work is to advocate for others. And it can be individuals, it can be your community, but also our nation. And so in November, young people in here, please vote. Vote and take a stand for people who are supporting services to individuals with mental health issues and substance voice. And so if it starts on a social media post, please repost back. We need voices to advocate for those, especially those who cannot advocate for them.
Thank you. Thank you all so much for coming tonight, and please give our panel a hand.